Hi, Dean.
Hey, Fernando.
Can you hear me?
I can hear you well.
Oh, great. Valerio, Baris, everybody's inside here. Great, great. Nice to have everybody. Great. So, all right, Dean. So let's start. Just a second, please. A lot of people coming in. Yeah, that's it. All right, Dean. How are you doing?
Really good.
You good?
Little cold here in Chicago area, but good.
Great. You don't like so much cold, right?
No, not really.
And you said that in winter you used to go to your summer house in Costa Rica, so now you cannot do that, right?
No, I'm stuck in the area.
Great, great. Dean, before we start, I'm going to speak very briefly in Portuguese and very briefly in Spanish also, because there are many people from Latin America watching us, right?
Okay.
And then we come back and we start, right?
Sure.
Ok. Bom, pessoal, primeiramente eu queria agradecer aí a presença de todos, né? Acho que foi muito bacana aí, estamos já com mais de 300 pessoas aí online. Não é à toa, né, que todo mundo entrou aqui para ver essa grande personalidade que é o Dr. TORIUMI, que não só é um cirurgião plástico excepcional, mas também uma pessoa que muitas pessoas não conhecem, né? Que às vezes nos congressos a gente acaba vendo só um lado dele, que é o lado profissional, e a parte pessoal a gente não conhece. Mas óbvio que nós vamos falar disso e também de coisas de rinoplastia, que é óbvio que todo mundo quer saber. Bueno, amigos de Latinoamérica, estoy muy contento de tenerlos todos acá. Yo sé que hay mucha gente de Latinoamérica que le gusta mucho la rinoplastia y es un placer muy grande tenerlos todos acá. También para hablarnos con esta persona excepcional que es Dr. TORIUMI, uno de los más grandes cirujanos plásticos en el mundo. Y nos va a hablar un poco de su vida, no solamente profesional, pero también personal, y vamos a preguntarle muchas cosas de rinoplastia también. All right, Dean. Thank you again for your time. I know that you're very busy. You do a lot of things on the same time. You're a very good time manager, but thank you for your time for being here with us. I'm sure that a lot of people in the world, you saw the little map that I posted on Instagram, a lot of people in the world registered for this talk because I think many people know you by the meetings. People know your wonderful lectures, and I'm not saying just it's not only my opinion, but a lot of renowned plastic surgeons consider you one of the best or the best rhinoplasty surgeon in the world. So that's why we have more than 400 people around the world here to watch you, and we're gonna talk, of course, about rhinoplasty, but also about some things that people don't have time to ask you in the meetings. So you're in a round table, you have 15 minutes, 20 minutes for your lecture, and they only can ask you things about your lecturing, not all the other things that you do to become a master in rhinoplasty. So thank you again for your time.
No, you're welcome.
All right, so let's start, Jean. What are you doing specifically on these days? Well, how are you spending your time? Are you still doing surgeries there, or you stopped?
I did my last surgery. I did a surgery on Monday. I haven't been doing many lately because the surgery center is only allowing us to do semi-urgent and no straight cosmetic procedures. But I did have a patient who had a infection in her nasal tip from a injection of a filler material, okay. And the skin was becoming compromised. So I took her back and I took her to surgery and took the filler out and put some fascia with some nano fat in there because the skin was vascularly compromised. But other than that, we're not doing any surgery. I'm just seeing post-op patients in the office, just making sure that they're okay. But pretty much the practice is not active right now. I'm occasionally doing a Skype interview. We're trying to stay in touch with patients in that fashion. So I do have more time.
Yeah, yeah, yeah. So tell me a little bit, what are you, I'm sure you have a lot of plans. I spent some time with you. I know that you wake up very early in the morning and you can manage many things on the same time. You write books and you do surgeries, you do workout and you take care of your health. And how is that? What are you doing on these days?
Well, I get up at 4 and I work out for a little over an hour. I do some aerobic weights, core, and then I'll start before everyone else is up. I'll start to get some things done. And what I've been doing lately, I've been doing a lot of catching up on some papers. I finished a couple papers recently. I started to write another book.
Really, really.
Yes, yes,
Tell,
yes.
tell us.
Not rhinoplasty though. The book is actually on the anti-inflammatory diet, and it's
Great.
something I've been doing myself for many years. Because you visited me, and
Yeah.
we've been around each other. It's something I'm pretty passionate about. I think it has a lot to do, or it's a good way for you to put yourself in a good mood right off the beginning of the day and keep yourself in good health. And it's what you eat and what you drink is the fuel. And if you have good fuel, then your body runs well.
Yeah, great. Yeah, I had the opportunity to be with you. And the first time I went to visit you, you told me about how strict you are with your diet. And since then, I'm also like copying you. In the morning, I have a shake with a lot of, yeah, a lot of antioxidant things and some kind of nowadays like brain octane, and also some things to give me energy for the whole day, because we have some long surgeries and a full day can be very stressful. So tell us a little bit about this shake that you do in the morning.
Yeah, well, the shake is green tea, which is the base. That's the fluid base. I add a couple cups of frozen blueberries. I add some ground flax seeds, chia seeds, and I also put in some egg white protein. And that's my protein source. And it works well for me. That's how I get my day started every morning.
Great. So we're talking about a very strict diet, and also you said that you wake up in the morning, very early in the morning. You exercise a lot, and also I took you as an example for me for this kind of strict diet, but also for a routine of exercise. You say that you exercise a lot your core, right? Because you have long time, a lot of many hours you stay operating and you stand up there and you have to have a very strong core to do the surgeries in a high performance, right?
Yes, to do this type of surgery, particularly rhinoplasty, for an extended period of time, you have to have a very strong core, particularly your neck and your lumbar and your thoracic area. And so, from my standpoint, the more core work I do, it seems like the better my body will hold up through the day. And I think that's a very important thing for longevity to our careers.
Yeah. uh, yeah. And when you're doing like uh, surgeries and you take care of your diet and also your body, I I I, I have a like a theory that uh, the work that we do, rhinoplasty is the most. I think we have more than 500 people watching us. I'm sure that most of them agree that rhinoplasty is one of the most difficult surgeries that in plastic surgery. So uh, every day when we do a rhinoplasty, we have to do a work in high performance. And if we compare ourselves with, for example, an athlete, an Olympic athlete, he has to do, for example, he has to run or swim that competition in high performance. But sometimes I feel that we have a high performance competition every day because we have to be in our best shape, in our best condition of mental health and physical health to do the best rhinoplasty you can. And I see a lot of this on you because when I spent some time with you, I saw that you take care of your body, you take care of your mental health, and nothing changes when you're doing a surgery. If you're having difficulties in the surgery, if it's a difficult case or an easy case, it seems that your mental status is always the same thing. How do you do that? What do you think about this high performance in rhinoplasty, and also what can you do to improve yourself every day to become a better rhinoplasty surgeon?
Yeah, so mentally you have to be very tough. Rhinoplasty, particularly when you start to extend yourself beyond primary and you start doing secondaries, you'll get into situations where there'll be a complex problem and you'll have to think on your feet, and you'll have to make calls and judgments and decisions very quickly. And this can be very stressful. Stress is not good for the thought, your thinking process. So you have to learn to almost have a Zen-like ability to control your emotions. You never want to get flustered, and you'll always want to think positively that you are able to move yourself from a difficult situation into a very stable situation. And, I've been doing this for over 30 years, and I've taught myself that I've been in so many different situations where I've had problems and difficulties in the middle of a surgery, where I've been able to work myself out of those issues. And this is something that is very important for anybody who wants to do rhinoplasty. Even a primary, you could be doing a primary and you could be doing something and get into trouble. The worst thing you can do is to get flustered. You want to be able to be confident. You want to know what the next step has to be, and there's three ways to do this. And probably one of the most important ways is to have a very broad knowledge base. So you have to have as many options in management as possible. Every time I see a problem, I want to have 2 or 3 different options on how to correct it. And then based on percentages of success that I've experienced in the past, I can make a good choice on where to go. Yeah. That's probably the most important thing. The other is, technically, you need to be able to execute properly. And, a lot of times we get sloppy, we get tired. And that's part of the physical part of it. That's why I work out and I try to eat well, because when you're mentally tired or you're physically tired, you're not able to perform to the highest level. And you absolutely have to be able to perform at the highest level when you're doing rhinoplasty, whether it's a simple case or a more complex case. And the other thing is, you have to have the patience. You absolutely have to have the patient's welfare at the top. Meaning, you have to think in your mind, if I do this technique on this patient, will this give the patient a good outcome? It's so important that you're able to give the patient their best possible outcome. And sometimes you'll get in a situation where you'll just say to yourself, well, maybe I'll try this technique. Well, maybe that's not the right technique. Maybe you need to do something that is going to be effective with a high success rate. And so these are things that I try to do, and I try to focus on to make sure that I'm able to give the patient the best possible outcome and keep a very steady level of concentration and a steady mindset.
Great. That's so great, because that means that we have tools, right? We have tools that we can sometimes train ourselves to, like a behavioral training and a mental training for difficult situations during the surgery, right?
Yes, yes, absolutely. We don't think about the mental part of it much because, as surgeons and doctors, we think very subjectively, in many ways, or excuse me, objectively. We always want to have data, 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 but you also have to be able to move yourself into a mode where you can be almost philosophical about your approach to things and be able to be confident, and then well read. Information is so important. All these things that are going on the internet right now, where people are able to learn things about preservation rhinoplasty, learn about structure rhinoplasty, and learn as much as possible. That's going to make you a better surgeon. Sometimes we get pigeonholed into a slot, and we say, well, I'm a student of this, and so you just do that. That just limits you. I'm a structure person, but I see the potential in preservation rhinoplasty. It makes a lot of sense to me, so I'm doing it now, and I'm excited about it.
Great,
But
great.
I still like the structure, so I'm kind of mixing them together. And I know you're doing that, Fernando. I mean, you'll always be a better surgeon if you're open-minded and you allow yourself to expand and learn as many techniques as possible, because that's the situation where you're having a problem in surgery and you thinking in your mind, what is the solution? The more possibilities you have and the more experience you have, the better likelihood that you're going to get a good outcome, and you're going to pull yourself out of that difficult situation and correct it.
That's so great to hear that from you because um, one day that we were together, you said something that I thought was really, really interesting because you said, "Oh, today I consider myself a better surgeon than 10 years ago." and
Yeah.
and for me it was like I was in the early stage, and I still think that I think, oh, how Dr. Dintorumi can still improve, but you keep improving, right? Because you have this kind of mindset that you can always improve and learn something new, and you keep your mind open, right?
Fernando, I think I'm better than I was 2 months ago,
Oh,
based on no, really, I'm serious, because I've started to incorporate some of these, some of the dorsal preservation stuff, and I think it has a definite utility in my practice. So that makes me a better surgeon, because now if I have a patient who's got a straight nose, nice dorsal lines, maybe a little bit narrow in the mid vault, the bones look great, and instead of taking that hump down and going through the whole reconstructive thing, I can do a push now. And that to me allows me to preserve all the good stuff, work around it, move it around, and
yeah,
then move down to the tip and do whatever I want to do. I mean, it really allows us to open up new avenues to, in a way, simplify the operation. I mean, any way we can simplify the operation, it's always going to be good. Um, but the bottom line is the outcome. And I have to say, I mean, the outcomes I'm getting so far have been good.
yeah. So that's something that I can say that I learned from you, and to keep my mind open for these kind of things. And that's why I also went to Turkey with Dr. Chakir to learn a little bit more about preservation. And since then, I've been talking, of course, about structural rhinoplasty, but also about preservation rhinoplasty. And a lot of people ask me in the meetings, "Oh, you were already with Dr. Dintorimi. What does he think about preservation?" And people think that your mind is closed to structure. And I try to explain to them that it's the opposite. You keep your mind really open to new things, and if you think it's really good, you try it. So that's good that you're explaining this here.
Yeah, the last thing I want to do, even though I'm 61, I'm kind of set in some ways. Maybe my diet is set,
Yeah,
but how I treat patients when I perform rhinoplasty is not. I mean, you listen to Saban, you listen to, Barish, I mean, all these people that are, Rollin, you listen to these people who are talking about this stuff, and it makes a lot of sense. And so I want to expand, my horizons. I want to, do some of these other things. Um, it's important, I think, to always try to improve yourself.
Yeah, that's great. And I'm sure you don't do this only in rhinoplasty, because I believe that we have like um, a way of thinking. We have a mindset that you use this mindset in all parts of your life, not only as a surgeon, but also in your personal life.
Yes, absolutely. I think, you know, my kids, my wife, they know I'm pretty steady. They know that I'm not the type of person that gets all upset. I can keep my composure, and I think that's a really good characteristic of a rhinoplasty surgeon, or a surgeon in general. I mean, I'm a golfer too, and golf is something that you can never perfect, and I could always be better. And so that's a sport that teaches me to be to keep my emotions under control, and to control my emotions, and to be consistent. I mean, these are all things that are in many ways similar.
Yeah, yeah. I tried golf also, and it's challenging you every time in every detail, right? So it's similar to, in some ways, to rhinoplasty.
Yeah, definitely.
So talking about making a link with these general situations, you say a lot of things about mental control. Do you do some kind of specific thing for to train your mental control, like yoga or meditation or something like that?
I don't do yoga and I don't do meditation, but I do spend a lot of time, um, put it this way, personal time. I have time where I'm working on things and I'm studying things, and that's the time that I use to really learn to focus. I exercise, and while I'm exercising, I try to focus on these things to try to make myself a better person. So, and I, I also have faith, and faith helps me a lot as well.
So you're never on your comfort zone, right?
No, I'm always trying to get better. Definitely always trying to get better.
Yeah, that's so great. So great. So, just a brief story about your book. You said that I was with you when, I think, when you were starting to write this book, and every year when I met you in some meetings, you say, "Oh, I'm still writing my book." So it started with one volume and finished with 3 volumes, right? Right. So how was this? How exciting was to put everything together? 30 years of experience in one book.
It was an amazing experience. Um, for me, I wanted to make a contribution to the specialty. I think rhinoplasty is such a special operation, and I felt I had something to offer. The difficult problem is to spend the time and effort to put it on paper, and it took me 4 years, and 4 years of sacrifice for my family, my wife, myself, and my friends. I didn't spend a lot of time with my friends during that period of time, but I wanted to finish this, and I wanted to finish it as quickly as possible. So basically, what I did was, in this book, or three set book, is to take you through the ups and downs that I experienced learning and trying to get better at rhinoplasty. So in my opinion, it's as much a biography as it is a novel, as it is, my techniques. And if you read it, you'll kind of feel like I'm sitting here talking to you. And that's the way I wanted it. I want it almost as a narrative, because I want surgeons to be able to see when something doesn't go well, or you're getting some bad outcomes. We need to change things. We don't want to keep making the same mistakes over and over again. And so by number one, putting this on paper, number two, allowing me to basically vent, It's been very good for me, and it's been very good for people who have been reading the book, because they're seeing, not all good outcomes. I show some bad outcomes and explain why they occurred and how to prevent that in the future. And that's probably one of the most important parts of the book is seeing what you shouldn't do in a lot of cases, and then how you correct it, and then how you prevent those problems in the future. This is something that's very important, and it may even be one of the most important things that you can learn from a textbook. You go in and you observe somebody and you'll see bits and pieces. Basically, I poured my heart out on 30 years of experience in that book. And the app that goes with it goes through a lot of videos, goes through a lot of other things that are supplemental to the book. But I found that by putting this out there, it's at least allowed me to make a contribution that I hope will help surgeons get better outcomes. Of course, techniques change over time. That's what the app's for, so I can update people on how things are changing. But the book was a very extensive experience for me. It was a time-consuming experience, but I'm very happy with it.
Great, great. I'm sure that's a book that every rhinoplasty surgeon should have in their home or office, because it's very complete. And you talked about like 30 years of experience in putting also some bad cases and good cases. And that's we're talking about learning curve, right?
Yeah.
What I feel in rhinoplasty is that maybe sometimes that we're doing some kind of technique or some kind of approach, and we think that is right, but we can only discover that technique doesn't work after 1 year or 2 years. But you spent like 1 year, 2 years doing the same thing on many patients. So the learning curve is so hard in rhinoplasty.
Yes, the learning curve is difficult. Things like rib cage grafting, starting to do secondaries. Those are more difficult things to grasp and perfect. And we never can master it, but we can get to a point where we're competent enough and we can get reproducible results. The whole secondary part is really integral, because not only is secondary important, but you need to be able to fix your own problems. And I think that's a complete rhinoplasty surgeon, where if you create a problem in one of your patients, you can correct it. And you may need to extend yourself to different techniques, more complicated techniques. But number one, you have to be confident, you have to be knowledgeable, and you have to be able to execute. And that is where when I make a distinction about where a rhinoplasty surgeon is in their development, that's what I look at. Number one, can they get themselves out of trouble? Number two, can they fix their own problems? And number three, can they be competent and good at doing secondary rhinoplasty? And that's what separates people who I believe would be considered, the top rhinoplasty surgeons, because secondary is difficult. Secondary is tough, but it's something that I think all of us should strive to be able to do. I mean, there's different levels of complexity with secondaries, but I think it's something that is something that we should look at and try to get competent at.
Yeah, that's great. Your book, I'm sure it works as a shortcut for many surgeons, because they can study there and check everything and try not to repeat the same mistakes, right? And also you talked about like having many options to do rhinoplasty and have like an arsenal, right, before doing any kind of rhinoplasty, both primary and secondary. So this is really important for young surgeons that are watching us. I think know that the learning curve is really long and sometimes tough to become a good rhinoplasty surgeon, and also learn to have this big arsenal of techniques that you can apply in the cases, right?
Yeah, I mean, when you're a beginner, I think it's better to start with a smaller armamentarium of techniques. Start with a smaller group of techniques that are less complicated. Columella strut, extension graft, dome suture. If you decide to do the preservation techniques for the upper 2/3, I think that's a good thing to consider. But you have to have other options if the patient has a problem that won't allow you to use those techniques, where you have to open the mid-vault and you have to reconstruct it with spreader grafts. So if you know how to do all these things, but just the basic things that'll get you through all the different parts of the nose, that's going to allow you to progress more quickly. You don't want to do too extensive. You don't want to have too many techniques, but you want to have just enough or a good range that's going to allow you to be efficient and also very successful in your outcomes. The other thing that probably one of the most important things I believe that younger surgeons, well, all surgeons have to do is have a really good ability to follow your patients long term. And when I say long term, I'm not talking about 3 months, 6 months, 9 months, a year. I mean, a lot of people, they'll let their patients go after 1 year. In the book, I show how things change dramatically after a year. And so that's, the 1 year outcome is not your final outcome. And if there's one of the most important points I would want to leave with all of you today is do really good rhinoplasty worksheets or diagrams and make extensive notes, intraoperative photographs, intraoperative measurements, and then follow your patients. Get them back to the office, whatever it takes, get them back to the office, follow them up. In my mind, it's more educational for you to see something that did not go well, study it, figure out what went wrong, what caused that bad outcome, and then that allows you to prevent it in the future. If all you're seeing is a 1 month, 2 month, 3 month outcomes and they all look good, but those patients are not good at 3 years, you're not making the right decisions and you're not seeing what your actual outcomes are. And this is so important. As a rhinoplasty surgeon, it's probably one of the most important things for me that allowed me to get better is to really follow those long-term outcomes carefully and then see what happens to the nose, because it's shocking. It is really shocking when you look at a 10-year post-op and you see, how the nose has changed.
I remember you taught me that. You said exactly that. Follow up your patients for more than 1 year and you will be shocked with some kind of that's tough, right? That's tough too.
No, it's tough. And you have to have thick skin as a rhinoplasty surgeon. You have to be able to, there's sometimes where I'll walk in a room and I'll see a patient and go, oh my gosh, did I do that? And I did that. And that's something that happened over 10 years. And so then I look at the worksheet, I look at the intraoperative photographs, and I try to figure out what I did that resulted in that outcome. And, when you do that, you can start to make associations. You can make decisions based on those long-term outcomes. And then when you see that a similar situation in the future, you can do something to prevent that bad outcome from occurring. It's such an educational process. It just makes you a better surgeon.
Yeah, and I'm a little curious. How are you combining preservation and structure? In which situations?
Well, first of all, Goxel gave a really great lecture yesterday. It was yesterday, and I don't know if Goxel's on the call, but I enjoyed watching it. So, I mean, you see all these people, a lot of the guys from Turkey who are doing the preservation stuff, and Milos, I'm learning a lot from him as well. And so, basically, what I've figured out is, if I have a patient who has a nice upper 2/3 and they don't have an S-shaped hump, they have a V-shaped hump, they have a pretty normal radix, I'm thinking this is a really good case for dorsal preservation. And then I, make a decision whether I'm going to do a pull down or a push down at this point, I'm doing mostly push downs. But then I can make decisions on if I want to do more of a bony cap removal, or I want to actually push down the bony vault. And it's interesting. I haven't done enough, and I don't have enough long-term outcome yet to make final judgments. But based on what I'm seeing, I'm pretty happy with it. And so I think there's a good opportunity here to mix the preservation with structure. And I still feel strongly about how I do the tip, and I like to use the structure methods for the tip area. But I think the dorsal preservation, the upper 2/3, particularly in those patients who are good candidates, I think is a really nice way to approach things. You can serve on cartilage. You don't have to go through the middle vault reconstruction process. The questions are, what's going to happen to the upper lats and the mid vault over time? Will it hold up? I don't see any reason why it shouldn't. But these are things that we want to keep in consideration. So going forward, I'm sure I will continue to pursue this, the dorsal preservation aspect of it, and I think there's room for mixing the two. We do have a meeting, in Turkey and Istanbul next year in June, which I think is going to be really exciting. That's going to be mixing structure and preservation, and that's Barish and Goxel and Rollin, and so I think it's going to be an exciting time. It's not that often I get really excited about stuff, and this is something that I'm excited about, is how these two can come together, and you can combine them in procedures, and just give patients better outcomes. I mean, it just makes it a better operation.
Yeah, I agree with that. I'm talking about this meeting. For everybody, we have almost 700 people watching us. It's scheduled for June 2021 in Istanbul, and it's not a meeting that preservation versus structural rhinoplasty. It's the opposite. It's preservation combined with structural rhinoplasty. So putting those two worlds together, and it's gonna be awesome. It's Turkey has many good rhinoplasty surgeons, and we're gonna put together the best guys of structure and best guys of preservation to teach us how to combine that, right? And it would be awesome, this meeting. And Jean, talk a little bit. I'm interested on this tip concept. Okay, you wrote an article, I think 10 years ago, and you did a revision recently about your tip concepts, and it's amazing how you are ahead of. At least in my case, you're ahead of time in front of some other plastic surgeons, because 10 years ago, you were already thinking about lights and shadows in the tip, and the correct position of the lateral crura to have better highlights and tip defining. What came first? You did that study, and then you started thinking about these tip definitions in lights and shadows, or you were already observing these lights and shadows and you did this study to prove your theory? What came first?
Well, what came first was my dissatisfaction with some of the tips that were done by just narrowing the tip cartilages. What I found is that it created a look that I wasn't happy with. And then I started to look at the tips that were nice looking, very pleasant and normal in appearance, versus the ones that I thought that didn't look great. And it was all about shadows, positioning, structure, where the shadows struck the nose, where the strong points are. And basically what it comes down to is a nice symmetric brow tip aesthetic line. Dorsal aesthetic lines come down. They're a little narrower in the mid vault, and they start to flare out towards the base, but you have this triangularity of the base, which is very important. Barish's whole concepts on tip, it's all really very similar. I mean, what we're trying to do is preserve stability in the bottom portion of the nose, keep a good strong arch between the tip lobule and alar lobule, and remove bulk and fullness in the area of the superalar groove, this, that area where the bulbous tip can cause problems. So we're manipulating the underlying structure of the tip to create surface changes. And the surface changes are dictated by how light strikes the nasal tip and the nose and the super tip and the mid-vault. There's a lot of different ways for us to do this. And that's why there's many different nasal tip techniques that we can use. So then you have to make decisions. I mean, do you want to take an approach where you're going to use grafts, or you want to take an approach where you're going to use mostly sutures? I think most are effective. And, a large number of my patients, I'll use dome sutures with a nalar rim graft or an articulated rim graft, like Rick uses. These are all really good options. The question is what happens when you start to get into more variant tip anatomy? And that's where I was having difficulty. I was having difficulty with the variant tip anatomy, meaning the dramatic cephalically positioned lateral crura, the concave lateral crura, asymmetric nasal tips, which were really problematic. And that's where the dome suture alone just wasn't doing it. And that's where, as well as the very severely underprojected and overprojected tips. So those are the ones where it seemed like those were all my cases. I mean, I didn't have a lot of these straightforward bulbous tips. I was getting, really extremes, overprojected, underprojected, asymmetric, and I was not getting the results I wanted. And so that's where I started to release lateral crura, use lateral crura strut grafts a la Jack Gunther, and then in some ways start repositioning. That was Sheen and Costantian talked about that early on. And so basically it's just using those similar techniques through an open approach, stabilizing with lateral crura strut grafts, and then putting the cartilages where I want to create the proper shadows. But at the same time, really providing good lateral wall support, because I'm looking for a good long-term outcome. And I didn't see that in a lot of the patients. I was just doing a dome suture with cephalic trim. I saw at 5 years, 10 years, there was alar retraction, asymmetries, shifting of the tip, and that was bothersome to me. And so that's why I shifted to adding a little more structure.
Okay, and what I saw every time I visited you, I was impressed that you don't remove a lot of cartilage, right? You try always to reposition and change the shape. The first time I went to visit you, I was used to remove a lot of cephalic portion of the lateral crura, and when I visit you, I saw you removing almost nothing. So I was like, whoa, how is doing that? But because you do the reposition in the correct position, you have your highlights, right?
Right. So the concept is similar to preservation, is we're not taking things out. Basically, we're just straightening things and flattening things and creating proper shadowing by changing the contour of the cartilages. And I find it, at least in my hands, easier to do it with some type of structure. But yeah, we don't have to do cephalic trim much anymore. We can limit it just to the cephalic portion of the dome. And if you think about that, think about how dramatic of a change that is from just 10 years ago. I mean, 10, 15 years ago, we would take 4 millimeters or 5 millimeters of cephalic trim and then leave 5 or 6 millimeters or 4 or 5 or 6 millimeters behind. I mean, most of us don't do that anymore. Most of us are leaving the majority of the lateral crus, and we're taking a millimeter or two, or we're doing a turn-in flap, something like that, where we're still using that cartilage. So no matter what we're doing, it's preserving the lateral crus, the majority of the lateral crus. And, that is such a good thing for the patients, because what that's going to do is we're going to have fewer patients with alar retraction, fewer patients with tip deformities, and that's going to make the patients have better outcomes and better function. And so for the most part, what we're doing, the trends are really positive.
Oh, that's great. And how about tip stability? You do a lot of Asian noses, right? And I know last time I talked to you, you said that tip stability is so important for everything you're going to do on the tip after that. So and you operate a lot of Asian nose in thick skin patients, and you do a very strong um, uh, a lot of strong grafts for this tip stability, right?
Yes, tip support. Well, the rhinoplasty, the tip work starts with the foundation, and the foundation is the stability of the base, which in my case is a caudal supple extension graft. And I find that to be the most efficient way to stabilize the base, because I count on a stable base if I'm going to be, shifting cartilages around. I don't want the tip to shift. I don't want the base to shift. And that's why the caudal supple extension graft is so important. It's similar to, in Rick Davis's work with, the tensioning, the caudal supple extension graft is key. So a lot of techniques that you're seeing require, a very strong foundation to your repair.
Yeah, every time I give lectures explaining about that, I compare like a house, right? You cannot take care of the roof if you don't have a good foundation and a good wall support. And so first you have to do that, and after that you have to take care of the shape of the roof. So it's just a good way that I use to explain to younger surgeons.
Right, and the drawback to that is that the tips are stiffer, and I'll be the first to admit that that is a disadvantage. I explain it to all the patients. I know the techniques that don't require the use of a strad or an extension graft, the tip's probably going to feel more natural. So, there are pros and cons to all these techniques, and this is important for us as surgeons to talk to our patients about that. Um, that doesn't mean that all the noses I do, I put an extension graft in. That's not the case. There are a lot of noses, I believe it or not, I still do endonasal cases.
Yeah.
And so, in those situations, I don't need to use a big caudal supple extension graft. I can maybe get away with a small little strut, or maybe I don't even need a strut. So, most of the cases that you see me show at meetings they're more significant changes, and those are the patients that are going to require more significant structural changes, and that would include the caudal supple extension graft.
That's great, Dean. All right, Dean. We have, like I said, almost 700 people watching here. I think we have almost 1 hour talk. I'm sure that people would love to keep talking to you for many hours here, but I know also that you have a very busy day, and I was talking to you here and putting together some characteristics of you. I know that every time I'm with you, I know that you do many things on the same time. You go to the operating room very early in the morning, you do 1 or 2 cases, sometimes more, and then you go to the office and you still do workout, you still take care of your diet, you play golf, you go fishing, you write many articles, you write books. So I don't know how can you manage all these things. So it's so difficult to manage your time doing all these things.
Well, at 61, one thing I have learned is that time management is really important. I have it helps to have a very understanding, loving wife, and my 2 girls are great, and I have a son-in-law, and my younger daughter has a very nice boyfriend, and so we're a tight-knit family. They understand my quirks and what I try to accomplish. I'm just I'm a goal-oriented person. That can be a drawback at times. I'm somewhat driven, especially when it comes to rhinoplasty. Rhinoplasty is very passionate to me. And, one thing that all of us who are listening today can say is that rhinoplasty is an unbelievable operation, and we're all blessed to be able to treat patients and perform rhinoplasty. It's an honor and a pleasure. With that comes a lot of responsibility. A lot of responsibility for us to be good doctors first. Be really important to follow these patients post-op and make sure that they're happy with their outcomes, and be understanding and empathetic if things don't look the way they should be and patients aren't happy. With the selfie age as it is now, patients are more demanding. They're looking at their nose at 3 weeks post-op, and they're not happy with how it looks in that fisheye lens on their iPhone. And so a lot of it requires us to act as almost, to hold their hands and be very empathetic and bring them through this difficult healing process. And so there's a lot that comes with the package of being an efficient and good rhinoplasty surgeon. It goes far beyond just being a technician. It goes into the realm of being able to talk to patients, empathize with them, learn, get better, and always strive to do your best. I mean, that's the bottom line. Don't rush through an operation. People ask me all the time. They go, Dean, how can you spend 3 hours plus on a primary? Well, because when I'm operating on that patient, I'm thinking, what do I have to do to give this patient the best possible outcome? So they're going to be happy post-op. And if things don't look right at the time of surgery, then I'm going to take it down and I'm going to put it back together again and until I'm satisfied, because I know what the endpoint needs to be intraoperatively and at the time of surgery. And if I don't, I will work and work and work until I hit that endpoint. And one way to do that is to not be on the clock. We can't be thinking about time, and you have to be thinking about the outcome on the table and then the long-term outcome following the patient post-op. If you can do those two things and maximize that, you're going to be a very successful rhinoplasty surgeon. And in this time in the pandemic, where we're all hunkered down and we're spending good time with our families and our families, it's a good time for us to reflect and look inside and say, what can I do to make myself a better person and a better rhinoplasty surgeon? And, we can write these down on a tab of paper or jot it down and, make 10 points, make 5 points on how you can make yourself better, and work on those while we have a little time off. Because, this may never happen again. We may never have this opportunity to spend so much time making ourselves better. And we just need to take advantage of that.
Yeah, so great words. I I have I've been doing some small interviews with some people that I consider successful people, and when you compare the mindset of these people like you, for example, and everybody have the same pattern, the same pattern and similar mindsets, and these characteristics of the mindset um, works also for you as a rhinoplasty surgeon, but also outside of the operating room. So just here in our brief conversation, we see that you are always trying to improve yourself, not only as a in your family, but also as a person, also in your diet or in your workout, but of course as a rhinoplasty surgeon. You're very resilient in front of difficult situations. I've seen you doing so difficult cases in the operating room, and you were like zen. We were. It seems that was nothing happened to you. If it was my case, I would be crazy about that. And you're a very good time manager. You do many things at the same time and everything with your perfectionism. And I know you work a lot. Not only you always say that you work your right side of the brain, right?
Yeah.
You don't practice just your ability to do the surgery, but you're always thinking with your right side of the brain and your artistic side, and you have focus on everything you do. We can check by every article you write or every book that you wrote and you're writing now. You have discipline, mental control, and you're never in your comfort zone. I call this package as a champion's mindset, because every champion, every successful person, they have all the same patterns, and you have all. So that's um, there's a reason for you to be such a successful surgeon and such an amazing person, and that I'm honored to be your friend and to know a little bit more about that. And when I thought about doing this interview with you, it's because I knew that you had some very good information, very nice tips for everybody, not only as a rhinoplasty surgeon, but also as a person. You gave a lot of important information, and you taught a lot of good things to everybody here. Thank you very much.
Fernando, thank you for setting this up, and thank you for being an ambassador and a
Oh,
friend.
thank you so much. So Dean, we're I don't want to take your time. Um, I'd like to thank everybody here that is watching us. We have almost 1 hour talk. I couldn't even, I thought it was just 20 minutes and it's almost 1 hour. A lot of people watching us. I'd like to thank everybody. Graças a todos de Latinoamérica. Obrigado a todos aí também do Brasil. I'm going to stay here in a little bit with people because there are many questions here, but I know you're very busy, so feel
No,
free.
I mean, if you want, I can stick around. I can take questions. Yeah,
Okay,
sure.
let me check here some questions and read here. Just a second. All right, so everybody who are watching us, if you have some questions, you know there are many questions, more than 100 here. I cannot answer everything, but let's check here. A lot of people thanking for your time, and oh, here. I'm gonna put there. Okay, how does Dr. TORIUMI deal with unhappy patients?
That's a good question. So, this gets back to the whole empathy part of it, being empathetic and listening to the patient. So the first thing you have to do is don't dismiss the patient. The tendency is that a patient comes in, they're unhappy with their outcome, and you're looking at them and you're saying, well, it's better than it was, so, and then you dismiss them. That's the worst thing you can do. What you want to do is look them right in the eye, be very calm, and listen. Listen to every word. If it takes 20 minutes for them to tell you what their issues are, to listen to them very carefully. Then what you can do is go over their nose and go over what the difficult parts are, the parts that didn't turn out, because we all know that we don't get perfection in rhinoplasty, whether it's the aesthetic or the functional part. And don't dismiss people who say they can't breathe through their nose. Look at the nose critically and then think to yourself, number one, can I make this better? And at my stage, I feel that when patients come in and there's an imperfection, for the most part, I can probably make it better, probably with some kind of minor revision. My revision rate now is higher than it's ever been in my career. Now, is that because my results are getting worse? No, it's because the patients want higher and higher expectations. And, what are my alternatives? My alternatives are to ignore the patient, send the patient away, but then you lose the patient out of your practice. If you think about it from a selfish point of view, you want to keep every patient in your practice, because then if you can make that patient a happy patient, that patient becomes a potential referral for your practice and another happy patient. So when I'm looking at the patient, I'm talking to them, I'm thinking, can I make this better? And so if I can, then I'm going to go ahead and do a revision on them when we talk about revision surgery. Now, there's some patients that are unrealistic, and you can't make them better, or you can't safely make them better. And in those situations, you tell the patient, my skill set doesn't allow me to really fix your problem, and I can help you get another surgeon, and you can assist them in that manner. But it's really important, in my mind, to listen, be empathetic, and don't dismiss the patient, because as surgeons, sometimes we tend to do that. And I'll tell you, I get a ton of patients who come to me from other surgeons, and I'm sure it's because they're looking at the patient and they're thinking, well, I don't want to deal with this, so let's send it to Chicago. So I mean, I'm have to deal with a lot of people who have unusual requests or whatever, and so that makes my job more difficult. But I'm open to it. I'm in a state of mind where I feel that I can counsel these patients and hopefully help them out. But that's a good question. I think managing the unhappy patient, it starts with being empathetic, listening to them, and then doing your best to try to make them a happy patient.
Well, that's, you said a very interesting information, because I don't have the data, but on the last year, maybe I thought that I was doing more revisions than usual in my practice, and I was questioning myself if it was because I was trying to mix new things of preservation and structure, and that's why I was like in the beginning of a learning curve, or because of patients that are more they want perfection, right? And maybe both things, but it's good you that you said that. Maybe I think everybody around the world face the same problem nowadays.
The other thing, Fernando, is when you start to do new techniques, you're going to have, some problems. I mean, I know surgeons, when they start to do repositioning, they can have some problems. That's why you want to tiptoe into these things. You want to start with just putting lateral strut grafts or just dome sutures alone, then maybe lateral strut grafts with dome sutures, but not repositioning. And then, in the patient who's a good candidate, consider the repositioning. But if you're having problems, then you have to step back, look at your intraoperative photographs, particularly the one that you take right at the end of the case, which I believe is very important. And you can even send that to me. Send it to me via an email, and I can tell you, what the problem is. I mean, the more minds we have looking at these things, the better off we're going to be. And more quickly we can improve our skills and become more efficient at techniques, the better the patient's outcomes will be.
Yeah. Oh, Valerio asking here, how does Professor TORIUMI deal with deviated noses with high septal deviation?
Well,
Thank you.
most of those patients, I'm going to expose the upper dorsum or expose the dorsal septum by opening the mid-vault and then putting in some type of splinting spreader graft, or doing, if there's a vertical fracture, I'll do a subtotal septal reconstruction. I know that the preservation guys are doing different techniques where they're manipulating the subdorsal area onto one or the other side of the dorsal septum, or maybe using a caudal maneuver. I have not done much of that as of this point in time, so I'm still opening those patients in the mid-vault area and splinting with spreader grafts or doing some type of septal reconstruction.
Oh, great. So we have here one more question. Body's question here.
Barish.
Yeah, Body's here. He's asking, what are the impacts of social, like the social media in your practice?
That's a good question. So it's a huge impact. I mean, it's a very significant impact, and the reason being, now when Barish is asking that, is he asking about how social media, my activity on social media, like Instagram and Facebook, is effect on my job? Is that the question?
He sent here, what did TORIUMI think about social media effect on?
Oh, all right. So what's the effect of social media maybe on our practices?
Yeah.
Or maybe on our jobs? I think the effect of social media on our task to perform rhinoplasty, it's making it difficult, because the patients are looking at their photographs on FaceTime, and they're taking selfies and sending them by Instagram to their friends, and they're seeing the nose doesn't look great and it still looks puffy, and some of that may be photographic from the fisheye on the Apple iPhone. So that's making it more difficult from that point of view. Now, with respect to our practices, I was a neophyte, or I still am a neophyte, when it comes to social media in practice marketing. I just haven't been, very up to snuff on that. I know, Barish, you're much more efficient at that and effective. But I have some people that I work with, Bridget in my office, and she's been very, very good at this, is helping me with Instagram and helping me with Facebook. And it's made a huge impact because particularly now when we can't, do face-to-face in the office with patients, it's allowing me to continue to communicate. And face it, if we're not using social media, you're not taking full advantage of what's out there. And so I think the use of social media in your practice, and this is coming from a dinosaur. I'm a 61-year-old guy who's been doing this for 31 years, and to make these changes now is tough. But I see huge utility. I think it's very important for us to be able to communicate with the patients and potential future patients. And so I think it's a good tool for us all to use. But we
Okay.
need to use it. We need to use it ethically. And I know the people I know are using it ethically and using it in a very effective manner. And I think we need to continue that way.
Oh, great. So a good question here from my friend from Brazil, Alessandro. He's asking about nanofat. I know you use a lot of
Yeah.
microfat, fat, and I think people would love to know your opinion about that.
Yeah, nanofat has been really revolutionary in many ways in my practice because I see a lot of patients who have compromised situations, meaning the soft tissue envelope. For instance, the patient I operated on this past week, she had multiple previous rhinoplasties, had Medpor in her nose, had filler put in her nose, and you could tell that the skin on her nose was compromised vascularly. But we had to get the filler out because it was infected. So we took the filler out, and then I took some temporalis fascia and infused it with microfat. And I've been doing this on a lot of the patients who have compromised skin. And what I'm seeing is a rejuvenation of the vascular supply to the tip skin and the dorsal skin in complex situations. And so it's helped me a lot in those cases. But those are extreme cases. In your more commonly performed cases, even thin skin primaries, I'll be using occasionally, temporalis fascia with microfat over the dorsum, or in patients with secondaries that have a lot of problems with skin contracture, I'll use the nanofat with fascia or perichondrium. When you do secondary rhinoplasty, one of the things that you find when you follow your patients long-term is the thin skin patients can contract over time, and contractile forces can be very damaging to your final outcome. And what I found, in the years I've been using the nanofat and the microfat is that if you enhance the soft tissue by injecting nanofat and in some patients microfat, depending if you want to augment the skin or not, underneath the skin envelope, it will help modulate the skin contracture. Because I've had patients I've operated on once contract, twice contract, third time I take them back, put in nanofat with temporalis fascia, and they don't contract. So what's the explanation for that? I think it has something to do with the stem cells and the stem cells' ability to control, to some extent, and modulate the healing process. And so I think there's a lot of potential there. And, we're continuing to do work in that area, and we'll see how it pans out.
An interesting question here. To whom do you send your unhappy patients, or if you
No, that's a good question. I don't want to, the unhappy patients I have, I just try to keep them in my practice. I know some of them are out there and they get to someone else's door. But I just try to keep them in my practice if I can and try to correct them if I possibly can. Occasionally, I do send a patient on. They just don't want to have me do another surgery, and I'll send them on. And those are mostly my friends. But I don't want to mention any names today.
Right.
You know who my friends are. So.
Sure. Okay. And about piezo, what do you think about piezo?
So, piezo I wasn't really big on because I just felt comfortable doing my bony work with my osteotomes and my rasps. But now that I'm doing the preservation, the dorsal preservation, I see the utility because, when I'm doing, my lateral osteotomies and my I use the transverse. I do the transverse bone cut, with Barish's little instrument across the radix or across the upper aspect of the hump reduction, and that works well. But connecting the two and working there, I think I could see how it'd be more efficient and easier to do with piezo. The problem here in the States is I can't get access to or I can't reuse the inserts, which I've talked to the people in the surgery center, and they're telling me if I use 3 heads, I'm going to throw out all 3 heads, and so it's going to be very costly. So, I'm trying to talk to the people in the surgery center to see if there's a way that we can, maybe decrease the cost. And so I've talked to Rick Davis about it, and he's just using one insert for the entire case, and that's a consideration. Because the more of this I do, the more important the piezo I think is going to be.
Great. One more question here from a colleague about your revisions, your percentage of revision in secondary cases, and I will complete my question about that. You tend to keep a little bit of cartilage behind the ear, and I've been doing that because I learned from you. Every time you need to use that for a small touch up or something that you can do even inside your office, you don't have to take your patient to the operating room. Do you consider that a revision also?
Yes. So when we do, how often do I do these revisions? In the secondaries that I do, it probably comes out to about 15%, a little over 15%. And like I said, that number's going higher. It could be getting closer to 20. So 1 out of 5 patients I need to take back for some type of minor touch-up. And, that's a pretty high number. But the thing is when I look at what the deformity is, a lot of them aren't that big, and I don't use filler in the nose. So if I have a patient who's got a small depression in the dorsum, which someone else would just put filler in, I have to take them to surgery and put a little piece of soft tissue in there. And so that's a revision. I count that as a revision. Or if I do some minor revision in the office, that's a revision. And so, my numbers are going up, but I'm happy with that. I can deal with that. I can deal with 20% because the ones that I do perform tend to be relatively minor. A caveat is that when you start to use rib, and in a lot of the cases there's no ear left, and so I don't have a choice but to use rib. Rib will increase your incidence of having to do revision cases. That's just the way it is, because rib is more complicated. It can bend, it can warp, it can do things that are unpredictable. So don't feel like you're incompetent because your revision rates are going up. It's just part of using rib. Now, do I use rib in cases where I don't have to use rib? Absolutely not. I mean, I'm using rib in cases where I feel it's necessary. But along with the territory comes a little bit of a higher revision rate. Don't feel bad about it. Explain it to the patients up front that you may have to have a revision surgery. Maybe you got a 1 out of 5, 1 out of 20 chance or whatever that you'll have to do this, and explain it to them, and then you'll have to maybe do a touch-up post-op. But when you're dealing with revision cases, the touch-ups, if you have good structure in your nose, will tend to be less complicated. And when you do bank the cartilage behind the ear, it's a nice place to go to get a little piece of cartilage, or even in many cases, I'll just take scar tissue from the banking site, and that's the soft tissue I use for filling small defects, and it's very effective and efficient. Just make sure when you put your cartilage back there, you put your incision so it does not sit where the glasses sit. You don't want the end of the glasses to sit right on that spot, and make sure it's deep enough so it doesn't become visible.
All right. And about extracorporeal septoplasty, how often do you use it?
So I don't do, the typical extracorporeal that Dr. Gubish does. I do what I call a subtotal septal reconstruction. So I leave cartilage attached to the ethmoid, and then I build off of that. And by doing that, I feel a little more comfortable with where where and how I can attach the cartilage back, and I think it's a little more stable. I use bilateral spreader grafts to put it back. I just don't feel comfortable doing the extracorporeal when I can leave a little bit of septum there. Now, there's some cases where the whole septum is really damaged, and then you might have to consider that. But I don't recall a case where I didn't have some cartilage that I left up at the ethmoid keystone area.
Okay. Oh, this is an interesting question because of this preservation thing. And how important, in your opinion, the Pitangui ligament is for support of the tip?
Yeah, I haven't quite figured this out yet. I don't preserve Pitangui's ligament when I do my open rhinoplasty approach. What I will do in some cases is leave a little stub of tissue there at the end, because sometimes I use a Bomb and Gyron super tip type suture, and that's a nice little stump that you can use to suture. It does make sense in some ways to reattach Pitanguis to then, eliminate the space in the super tip area. The problem I have is I do a lot of movement of the tip. I'll move it up, move it down, move it back. And so Pitanguis doesn't line up anymore. And so for me, a lot of times I can't reattach Pitanguis just because of the movement of the tip, maybe lengthening, shortening, whatever, a lot more projection, maybe repositioning the lateral crura. But, in my mind, it makes sense to kill that dead space, to close that dead space by reattaching Pitanguis. I just haven't done much of that. I used to do all my opens about 18, 19 years ago. There was a period of 4 or 5 years where I did all my opens sub-perichondrial, and then I did sub-periosteal dissections over the dorsum and over the tip. And I think I did have less bruising and swelling, but part of the problem is that the cartilages I thought were weakened. I lost inherent strength in the cartilage, so it was less able to hold the suture, and they tore a little bit easier. So I went away from that, and so now I leave the perichondrium on the cartilage for that little added extra support. And I think the soft tissue on the cartilage also helps with holding the sutures in place, because it fibroses a little bit more around the suture. But again, I think there is merit to closing that space by maybe reattaching Pitanguis if everything lines up properly.
Okay, I'll make you the same question that I did to Barry's, because you do a lot of thick skin patients and a lot of Asian noses. Talking about this dissection, superchondral, Dr. Vincent showed as a lecture, and he explains the histology. When you do the superchondral, you don't form any scar tissue. But when you do subcutaneous or subsmass, you would create some kind of scar tissue. And what's your opinion about that in thick skin patients? Would you do like subcutaneous or subsmass dissection to make the skin thinner and deal with the scar process after the surgery? Or would you try to do superchondral and improve the structure to like mark the skin and avoid some kind of scar tissue? What's your opinion on that?
Yeah, I think that depends primarily on how I'm going to change the structure. If I'm going to change the structure by projecting into thick skin to stretch it, then I'm probably going to go more subcutaneous and take some of that tissue out, because I feel comfortable with the expansion of the structure, that I'm not going to have a problem as much with dead space. But when the structure stays the same size and I have a big thick skin envelope, or I need to make the structure smaller, then I think it makes sense to go subperichondrial and then maybe try to reattach some of that back down. So a lot of the thicker skin noses, I am trying to make the structure bigger and project into the thicker skin. And then I don't think I have much of a problem because the skin envelope is being stretched.
Okay. And related to these thick skin patients, how do you manage fibrosis in the post-operative? Do you use Accutane or any kind of other treatment?
No, I don't use Accutane. I do use Kenalog. I do use Kenalog. I find it very effective. I tape the noses post-op, and usually the combination of those two allow me to get where I need to be. The other thing I've been doing a lot of lately, and Milos has talked about this a little bit, is I use irrigation or suction catheters a lot. And so I'll leave a suction catheter in the nose underneath the envelope to suction drain blood out. And I think I talk about this in the book as well, because I think what happens in some of these patients is they ooze serous fluid or blood, gets under the skin envelope, creates fibrosis, which then adds to the thickness. And so if we can keep that from forming, then I think it's going to be better in the long run for the patient. And so you see a lot of TORIUMI rhinoplasty patients in Chicago walking around with these little tubes hanging out of their nose, and that's what it is. It's either for irrigation, for antibiotic solution, or suction to remove blood, one of the two.
Okay, great. And my friend here from Brazil is asking if the patient is happy with the result, but you are not happy with the result. What would you do?
Yeah, that's a good question. There's been several times where I've had a patient who I did not like the result, and they were happy, and I brought the topic up. I said, hey, maybe we can make it a little bit better, just because I don't want someone walking around with a nose that could be better, and that's just part of my type A, I guess. In fact, if I have a patient who has a not so great nose and they have some trauma to their nose, we're gonna fix that, and we're gonna take that as an opportunity to fix their nose and make it better. So, if I have an unhappy, or if I have a patient who has a not so great outcome, and it's something I think I can make better, but the patient for the most part is happy about it, I will frequently bring it up and talk to them about it. And, a lot of times, most of the time, they say, no, Dr. TORIUMI, I'm happy with this. And then we'll just leave it at that.
Okay, great. Right. And can we continue or?
Yeah, go ahead.
Okay.
One thing I just want to mention before we go forward is that I do have a 1-year anniversary special on my book right now, and we have free shipping for within the U.S. and $100 off international shipping. And if you want, you can go to TORIUMIrhinoplastybook.com if you're interested. So, yeah, that's the book, right? So now I'll put the book there. If you don't like it, send it back. All right, so you could go ahead with the question.
Yeah, I know your answer about that because I already asked you this, but I think many people are interested in that. What do you think about fillers in the nose?
I don't use fillers in the nose. It's unfortunate, but for some reason, I see a lot of complications from fillers. I know most of you who do it probably don't see it, but I don't. Maybe I'm just seeing the unique group of people who are having problems. I see patients with vascular compromise. I see patients with chronic infections. I think what happens in some of these patients is they have the filler and it's there, and because it's like in a globule, it doesn't resorb, so it sits there for years. And then, they get little bacterial infiltrations of that area, and it causes a chronic infection. And once we take the filler out, then they're better. So it's a problem. And my fear is that we're going to have, a group of patients that are vascularly compromised because of the fillers potentially. I don't fault anybody who uses it if they use it properly, injecting it deep. I just feel philosophically in my mind, I'm not going to use it. And one of the reasons is I'm a purist when it comes to rhinoplasty. I just feel like we as surgeons need to do the best job we can at the time of surgery, get everything just right, and then deal with the consequences post-op. If we're putting filler in all of our patients, then maybe we get sloppy at the time of surgery and we think, well, if I leave a depression there, I can fix that post-op. I can just throw a little filler in that. I don't want to ever be in that mindset. I want to always be in the mindset where I want to get the nose as perfect as I possibly can at the time of surgery and never think about falling back on a filler post-op.
Great, great. I have a question here, and I'm gonna complete a little bit. Um, Dr. Sergio is asking about the lateral crural repositioning. We know that you do a lot, and it's amazing for the tip contour, right? But with the lateral crural tensioning or articulated ring graft, do you think your rate for repositioning and are less than the best? Like the lateral crural steel with lateral crural tensioning and all other ring articulated ring graft. Do you think it can deal a little bit with the malpositioning?
But basically, the thought behind that is that by tensioning, you're hiding the malpositioned bulbous lateral crus. And actually, I've been doing that in Asian patients for years. I will not move the lateral crura in Asian patients. I'll just tension them on a big caudal septal extension graft and then build around it. And I think it works. I think it's great. As long as you control the lateral compartment, meaning control the alar margin, and that can be done with an alar rim graft, articulated alar rim graft, to prevent contracture or alar retraction, then I think you're good. I just feel more comfortable if I can put a little bit more support in the sidewall. And then one thing I did find in some of my patients that I did tension years ago is that I think that the connection to the sesamoid laterally loosens a little bit over time. And as it loosens, then some of the bulbosity can come back. That doesn't happen in all patients. It happened in a small percentage of my patients, but that's what I thought was happening when I was doing tensioning type, because I've been using caudal septal extension grafts for years. And what I was doing is just pulling them tight on the extension graft like Rick Davis does. And then I put just a regular rim graft in. And they would look good for a long time. But then what I saw in some patients, not all, just some patients, I would see a return of some of the bulbosity. And I think that might be, I think it's not from failure of the connection of the dome to the extension graft. I think it's possibly loosening of the lateral crus laterally at the sesamoids, because think about that, it's just a soft tissue attachment. And if as time goes by, if that loosens, then maybe you get a little more bulbosity that returns. But again, I think it's a very good technique. I've done it in many patients. I still do it to this day in Asian patients. And so I think it just, again, it's one of these things where you want to be able to be capable of using a number of techniques to manage the tip, whether it's a turn-in flap that I've done, whether it's dome sutures, whether it's repositioning lateral strut grafts without repositioning, articulated rim grafts with tensioning, shield tip grafts. I mean, a lot of times we forget that a shield graft is a really good option, particularly in thick skin patients. I mean, shield grafts are tremendous, but you just have to use them properly. So if you're a surgeon and you have capability of doing all these techniques and do it efficiently and know when to use it, just think how more diverse your patient population can be and how you can raise the level of your results on difficult primaries and secondaries just by having a wide range of options when you pick tip techniques. It's just, I think it's so important. So the only thing I don't do is vertical dome division. I just don't do vertical dome division anymore. I did it in the past. I don't do it anymore. Whenever I'm thinking about dividing the domes, I just release and reposition.
Okay. Yeah, that's so interesting. I've never thought about loosening the sesamoids. I never thought about it because we tend to think fix the point, right? And when we think that it can loosen it, it changes your indications or maybe your mind. That's very interesting. Okay, one more question here. What is your most common cause of functional problem?
The most common problem functionally is actually, in my hands, is a fullness in the septum that I create from a sliver graft used to stabilize an extension graft. Believe it or not, that is an iatrogenic problem that I've created intranasally where the patient comes in and they go, Dr. TORIUMI, I'm having difficulty breathing out of this nostril. And I look in there with the speculum and I see a bump on the septum. And what is that? It's a piece of ethmoid bone that I put there that wasn't burred down appropriately, and it's blocking the airway. Now, it's an easy fix. In the office, I can make a little mucosal incision and take it out, but it just illustrates the importance of being very cautious when you use some type of splinting graft to splint an extension graft. So, that's why when I use rib cartilage, I use these really, really thin slivers of the costal cartilage, which are perfect because there's virtually no bulk. But if you use ethmoid bone, it's really easy to make the bone too thick and then block your airway. And then it's a problem. You'll look in the nose and the first thing you'll see is that bump. And where's the bump coming from? The bump is from the bone that we put in there to stabilize that. So a couple ways to prevent that is make sure that you take out a pineapple burr or something and you burr down that bone so it's paper thin, or just use really thin ethmoid that you think is so thin it's not strong enough, but you can run a needle through it. That may be strong enough to correct that. The other option is to use some little piece of PDS plate. I used to use more of those, but now I use more slivers of cartilage. But ethmoid bone works. Don't use vomer, it's too thick unless you really burr it down. Thin slivers of cartilage, and then you can just use suturing maneuvers. I know Rick uses like a little figure of 8. You can use multiple figure of 8, but just be cautious when you do that. Make sure that your grafts are along the floor and not towards the valve, because if it's a little blockage towards the floor, it's going to be less of an impact if it's up towards the valve.
And how many months after this surgery you can remove these levers? If there's
you can wait 6 weeks to 2 months, and you can take a little local anesthetic, inject it in there, make a small 1 centimeter incision, and then you can peel that little graft out. But again, the key is prevention. The other thing is look in the nose at the end of your case and palpate the septum, and if you feel fullness there, then you might have to make a little incision there and then take that little graft out or something. The key, though, is it's hard for you to do that because you're at the end of the case. You don't want to take things apart. So just be very careful through the procedure, looking at that so that prior to putting all your flaps down that you're not creating bulk there that's going to block the airway. And someone like an Asian patient with a big, wide vestibule, it's probably not going to be an issue. But, Caucasian patients with a more vertical, narrower vestibule, it can be a big problem.
Many details to pay attention. And, Dr. Goxel, great. It's an honor, Dr. Goxel. A question here. What is your opinion about this pandemic and when we will be able to turn our operating room back?
That's a good question. Well, first of all, Goxel, good lecture the other day. I appreciated it. It was good work. To answer your question, I don't know. I mean, no one knows. I mean, we're having a really tough time right now in the U.S. and we're trying to get through this. New York has had it really tough, and we're trying to push through with distancing at 6 feet and avoiding, washing our hands a lot. We're hoping that sometime in, maybe May, sometime in May that we can get back. We're also looking at these new treatments that are coming out, the hydroxychloroquine combined with the Z-Pak, and maybe some of the immunotherapies with the serum from patients who have recovered. Maybe there's some, or plasma from those patients could be helpful. But it's a very trying time in the U.S. now. We're praying for the government, for President Trump to make right decisions and get us through this. And hopefully we can help recover our economy, because our economy that was very strong is now in a very difficult situation. And we need a lot of prayers, and we need to be really vigilant in how we take care of ourselves, our family, and our friends.
Great. Thanks, Dr. Goxel. Maybe someday we can take this time with Dr. Goxel, Baris, Valerio, Nazim, and TORIUMI and do another big meeting, online meeting.
I look forward to working with all of you guys in Istanbul next June. I think it'll be great. It'll be a lot of fun. I'm hearing it's probably going to be a big meeting, and it'll be an exciting time because we'll be hungry for information. Because of all this we're going through now, missing Enrico's meeting in in Bergamo, which is such a great meeting. And I'm hoping that I know he'll put a good meeting on in February, this coming February, and then we are very hopeful for this big meeting in Istanbul. It'll be a lot of fun.
Yeah, yeah, I'm sure. I'm sure it's gonna be a great big meeting, rhinoplasty meeting, maybe one of the biggest. Okay, so can we have one more question? Are you tired?
Go ahead,
Go
shoot.
ahead. All right. Let's go here. Um, about Euler rim. Do you think that the indication of Euler rim is a valid way to fix a problem caused by the interdomal stitch?
Yeah, so the interdomal stitch, when you put it in, sometimes you'll get deformity of the dome or the area of the lateral crus just lateral to the dome. You'll get a little pinching there, and that can create a shadow just lateral to the tip structure as it transitions to the alar lobule. I'll always look for that. When I put a dome suture in, I'll go to the head of the bed, I'll go to the base, and I'm looking for a little disruption in the transition between the tip lobule and alar lobule. If I see that, then I'm going to put in a rim graft. Rod Rourke talks about the classic alar rim graft that's not really fixed to anything. That's probably an adequate graft to use in that situation. Otherwise, Rick's articulated rim graft is another good option. But whatever it takes, you want to create good support along the region of your marginal incision to stabilize that junction between the tip lobule, meaning the tip structure, and as you transition out to the alar lobule. And then when you look at the base, you're going to see triangularity. If you have triangularity at the base, your shadowing in your tip's going to be much better. You won't get the isolation of the tip, which creates that ball or round effect to the tip. And that's what we're trying to avoid when we look at shadowing.
Okay. It's Dr. Gabriel, my fellow. What do you think about some cases where the alar strut causes like a protrusion internally and limits the internal nasal valve?
Yeah, so that can be a problem. The ways you prevent that, and probably the most important factor to prevent that, is when you put your lateral curl strut graft in, it needs to be curved, slight curvature, and the concave surface goes medial toward the airway. That, if you do that and you make your graft 1 millimeter or slightly thicker than 1 millimeter in thickness, you shouldn't have a problem with that. You just shouldn't, because it's going to be, the graft is outward curved, so the outward curvature of the graft stents out the lateral crus a little bit and keeps the airway open so that you don't see the graft. If you're seeing the graft intranasally and it's blocking your airway, then your graft is either straight or it's concave medial or it's too thick, one of those three things. And so that is definitely a completely preventable problem. It's more of an issue if you have rib, because the rib grafts are thicker, and in those situations you can bevel the cartilage. So bevel the caudal margin and thin it out a little bit more caudally, and that will allow you to better hide that edge, and that will open up the airway. You want to put the bulk of the graft in the vertical convexity of the cartilage, and if you do that, then it's not going to impact the airway.
Great, great. Another question here: how do you avoid infection when you use costal cartilage? I know you use irrigation, and you told me once that after you started doing irrigation, your rate of infection almost went to zero. So tell us about that.
Yeah, so the rib cartilage, anytime you do a rib cartilage graft, the patient population you're operating on is at higher risk for infection. Revisions, a lot of them have, they'll have bacteria in their nose, maybe MRSA, some other type of bacteria, maybe even a fungus. So basically what you want to do is, what I'll do is I'll leave the perichondrium on the cartilage, first of all. So if you leave perichondrium on the cartilage, it protects the cartilage if you do have an infection, and it will allow your cartilage to survive. That's particularly important in very young patients or older patients. The other thing you do is I use these irrigation catheters. They're like 22 gauge angiocaths, and I put them through a marginal incision, suture them through the lateral wall splints we put in, and then I have the patients irrigate with either a Cipro or clindamycin solution, half a cc, very, very slowly every 3 hours. And I do that in all the secondaries and the rib cases that are primaries, like bad saddles or whatever. And, I'm telling you, it basically eliminates the chance of infection because you're irrigating in the area where the infection would occur. So if you're not allowing a nidus of bacteria to collect. And knock on wood, it's been very effective for me to prevent infection. And my patient population is very high risk for infection. And we'll use those irrigation catheters, and they work really well. You leave them in for 3, 4, in a really severe case, 5 days. Again, every 3 hours while the patient's awake, half a cc, very slowly.
Perfect. Oh, this is better than any meeting and any lecture. A lot of here we're really learning from you, because sometimes in meetings it's very quick and we don't have time to ask you questions. So thank you again for your time. Can we go for one last question?
All right, one last question.
Okay. How important do you think the artistic knowledge, like drawing, sculpture, is for rhinoplasty surgeons?
I think that's the right brain we were talking about before, Fernando. I think the artistic aspect is very, very important. You need to know what your goal is, and the goal is the shadowing and the structure and the shape of the tip, and that's where it helps to read Barish's stuff, read Rollins stuff, read some of my stuff. And if you look at that, Sheen has a lot of good stuff too. If you look at that stuff and you start to study what your goal is, then it can take a lot of the artistic aspects out of it, because some people's right brain, that's just not as effective. Maybe they're more left brain sided. They're more, and then if you don't have that, you have to compensate somehow. So if you can learn to visualize what the outcome needs to be by studying all these people's aesthetics and how they come to their aesthetics, then you can get to that outcome. Because if you don't know what your endpoint is, then it's difficult to even get a good result. So that's why the right brain is important, but even more importantly is knowing what makes up a good looking tip. I mean, that is probably one of the most basic primary things that you need to learn right away. That's before you even start doing rhinoplasty. You need to know what your goal is. And the goal is going to be an aesthetically pleasing, natural looking tip with proper shadowing. The light strikes it properly. The high points, the low points, are in the right place.
Perfect. Amazing, Dean. Thank you. Thank you again. You're a true idol for me and for many people who were watching us today. I'd like to thank you again for your time and for all your knowledge, because you're a true champion, because you have your success is not occasional. Your success is because you have a champion's mindset and you have patterns that makes you so unique like you are. Thank you again for
you're welcome.
Yeah,
it's a pleasure. It's a pleasure.
It's amazing. It was almost 2 hours talking to you. I'm sure that most of the people in the world wouldn't have this time to talk to you. So that's unique. Thank you. Thank you again.
You're welcome.
All right, Dean. Feel free to leave the room. Okay, I know you have things to do. Thank you. Thank you again.
Thank you very much. Good evening.
All right, you too. Bye bye. All right. I'm going to. That was amazing, right? I'm really happy with this talk, because we cannot have this opportunity every day to talk to a person like him and ask him questions that we would never ask in a regular meeting. We don't have time for that, and he doesn't have time for this also. So there are good things, good points about this COVID and pandemic situation. A lot of big names like Dr. Chuck here, Valerio, Dr. Goxel, and I'm sure other big names of plastic surgery in the world were here today. And thank you again, everybody. It was something very good and very unique. Thank you all. Gracias a todos amigos de Latinoamérica por la participación. Foi fantástico, ok? E todos os amigos aí do Brasil, obrigado aí também pelo suporte. Foi muito bacana. E vamos ver se a gente faz mais aí. So I'm going to speak English here. We still have almost 400 people here. We have already scheduled Valerio. We're going to talk to Valerio. I'm going to post in Instagram later the correct date. We can talk a lot about his technique and his preservation techniques, his instruments. So keep watching our Instagram. We're gonna advertise very soon this live talk with Valerio. Okay? Thank you so much. Bye bye. Obrigado a todos.